Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today we are going to talk about the fetal mutations and how do we can prevent them, or probably we can really filter them out. Meaning thereby that probably is there any possibility by which I can really identify that my fetus is devoid of any mutations before doing the transfer or before implanting into my uterus, right? So this technology or this technique is called as a PGD. PGD meaning thereby pre-gestational, meaning thereby that this is an adjunct to an IVF in which we have made the embryos outside the mother's womb or into vitro, meaning thereby that into the labs, and then we are doing some testing onto those embryos so as to identify is there any way by which we can identify or I can identify whether my fetuses which I intend to transfer in vivo into my body, into my uterus, are devoid of any mutations, right? So in nutshell we'll talk about this PGD or PGT. Can be divided into A, M, and SR. M is for mutations, A is for aneuploidy, and SR is for structural rearrangements in the chromosomes. So if we identify that either of the parents could be a balanced translocation carrier, the same thing can be identified in the embryos. And then if we had identified that the both the parents they are a carrier for a genetic mutations, meaning thereby there it is we are trying to look around for an autosomal recessive conditions in which we've identified the mutation in the blood in both the father and the mother, and therefore the similar thing can be identified in the embryos. Third is the aneuploidy. Aneuploidy is this that probably we just want to rule out the common aneuploidies for 13, 18, 21 and an X and Y to the fetus, right? So, but the question is this a foolproof sort of a technique? If it turns out to be normal, then also is there any risk that probably I can have the baby being affected with genetic mutations? And how does all these things go about all those things, right? So let us first go through these slides, and then probably we'll talk about these niggling problems. So as I've told you, PGD can be divided into M, A, and SR. M is for mutations, A is for aneuploidy, and SR is for structural rearrangements, right? And M is this for a look for to look around for autosomal recessive conditions in which we identified the mutations in the both in the parents. And A is for aneuploidy for 13, 18, 21 common chromosomal abnormalities that probably we are trying to look around for. Structural rearrangements, which is called as an PGDSR, is this, then we identify that either of the parents could be a carrier for a balanced chromosomal translocation, and therefore we are trying to look around for the same thing in the embryos, right? And what we've identified is this that they are absolutely, but technique wise they are good, but they are not the foolproof thing to look around for, right? So 3 to 5% is could be the false positives and negatives both with the M, A, and SR, right? And why is it so? This is what it is. So inner cell mass makes the fetus, and then the embryo biopsy is being done from a trophectoderm. So what can happen is this that once we're taking the cell, so this could be true representative of the fetus, could be a mosaic or could be an abnormal. So leading to both false positive and negative. By the face of it, what we can think is that the PGD should work. But then this is a technical flaw, meaning thereby that you really cannot touch the inner cell mass which makes the fetus. So we do an embryo biopsy from a trophectoderm cells, which actually is going to make the placenta. So what we believe and assume that trophectoderm should match genetically as to the ICM, meaning thereby that the placental makeup, genetic makeup of the placenta should match to the fetus, but should happen 100% of the cases. It really doesn't happen that way, right? Similarly, we can have, since we are taking only one cell and then we are trying to look around for that mutation in a PGDM, so there could be some possibility of an allele dropout, and so meaning thereby that there both for the false positive as well as with the negatives can remain in the range of the 3 to 5%. So this is true both for all of the three conditions, whether we talk about PGTM, A as well as an SR. So the SR would not be able to identify whether the fetus is having a normal karyotype or a balanced chromosomal translocation is there in the fetus. Similarly, as the aneuploidy is concerned, meaning thereby that this is the part of the placenta, and what we've identified, we do have a lot of videos in which I have told that PGDA normal can also lead to an abnormal fetus, and PGD a abnormal can also lead to a normal fetus. So what happens is this, that we do have an element of a trisomy rescue. So meaning thereby that the inner cell mass has got internal controls in which it tries to look around for the genetic makeup of all the cells. So meaning thereby that there's some sort of a negative control which is happening into the cells, and therefore the cells which are sort of genetically aneuploid or abnormal, they die down, and therefore the cells which is normal, they really grow bigger and bigger and more, and ultimately the fetus, what happens is this, that it is being a lot of cells which is normal, and therefore the cells which are aneuploid जो खराब होते हैं वो they usually die down on their own. पहला. So meaning thereby in a nutshell, what we can identify it is this, that 97, 96 पर 96, 97% it should work. तो अच्छी बात ये है कि जो ऑटोसोमल रिसेसिव कंडीशंस हैं, जैसे कि फादर मदर और द मेल एंड द फीमेल पार्टनर्स, दे डू हैव द जेनेटिक म्यूटेशंस, so the risk of recurrence could be 25%. So that probably will identified at 13 weeks by doing a CVS and all those stuff. The risk तो 25% की रहती ही है. So after we do the invasive procedure and identify that my baby is being affected, and then therefore then there is the risk of doing an irreversible call with the pregnancy. So that is huge. Now, how does a PGDM really helps us out is this, that the risk from 25% decreases to as minimal as 3%. So meaning thereby that all our sort of an societies, both in the American and the British society, they always implement and complement that in prenatal invasive testing should always be done in conjunction with the this prenatal testings, so as to confirm the genetic makeup of the baby, right? So SR is this, that the fetus is that this technique is not able to identify between a balanced or a normal karyotype. PGDA is this, that there are a lot of aneuploidies which keep on accumulating. They can accumulate afterwards after the baby is born, or they can get rid of their on its own. As far as the mutation is concerned, what we can see is this, that there could be some element of an ADO which is called as an allele dropout, and therefore it doesn't represent 100% of the inner cell mass. The trophectoderm cell biopsy that probably we do, right? So hope this should settle it out, right? Thank you very much for your patience.